Hello everyone. Continuing with the quick review series, today I am going to discuss about the management part of myasthenia gravis. This is one of those neurological emergencies where you have to act very fast, and this is a condition which is treatable. Okay, there are very few conditions in neurology that are treatable, and this is one of them. Okay, so the treatment of myasthenia gravis, the first thing you should know is the patient can present at an acute phase in myasthenic crisis, or they may present in a chronic phase also. So first of all, I will be discussing about the drugs that are used, the modalities that are used to treat the condition, and then I will be telling how which drug to be used at in which condition. Okay. So start with acetylcholinesterase inhibitor. This is the mainstay of therapy in myasthenia gravis. Okay, this is the mainstay of therapy. Remember, acetylcholinesterase inhibitor. The examples are physostigmine, neostigmine, pyridostigmine, and all. But the most important drug or the most effective drug that is used for patients with myasthenia gravis is pyridostigmine. Pyridostigmine. The dose is 30 to 60 mg. 30 to 60 mg. Q6 hourly. 30 to 60 mg. Q6 hourly. Now you can also gradually increase the dose, but the maximum acceptable dose that should be used ideally is around 300 mg. If the patient is not responding to this much dose of pyridostigmine, then there is no point in increasing the dose beyond this. So maximum acceptable dose is 300 mg. The more you increase the dose, the more likelihood that the patient will be developing cholinergic symptoms. Okay, the patient will develop cholinergic symptoms. So if the patient develops symptoms of cholinergic excess like diarrhea, or increased salivation like this. So these are some of symptoms that these patients can develop. This can be easily managed by diphenoxylate. Atropine is rarely used, but can be used, and also loperamide for diarrhea can be used. Loperamide for diarrhea. The usual effect of pyridostigmine starts from 15 to 20 minutes after the dose, 15 to 20 minutes, and this lasts for up to 4 hours. Okay, the effect lasts for 4 hours. That's why we need a more frequent dosing. That is usually the dosing schedule that is preferred is 6 hourly. Okay, so 4 pills per day, 4 times a day. One important point about this acetylcholinesterase inhibitor is they are not effective. In patients having anti-musk antibody. When we will discuss about myasthenia gravis, the pathophysiology, then I'll be telling that myasthenia gravis patient usually they have antibody against the acetylcholine receptor, but those patients who do not have antibody against acetylcholine receptor, they may have antibody against the musk antigen. So anti-musk antibody may be present in those cases. If the patient has anti-musk antibody, they will not respond. To this pyridostigmine or acetylcholinesterase inhibitor. Okay. So what is the treatment for that? That we will be discussing later. For the timing, remember that pyridostigmine is not useful for patients having anti-musk antibodies. The second modality is thymectomy. Now, for which patient you want to do thymectomy? Thymectomy is done for patients those who have thymoma. Those who have thymoma definitely will do. There is no doubt in that. But if the patient has generalized myasthenia gravis and acetylcholine receptor antibody is positive, these patients also you can go for thymectomy. Now, studies have shown that thymectomy in these patients have shown significant improvement in the symptoms, and that has led to reduction in the dose of the immunosuppressive therapy that is used in those cases. So, generalized myasthenia gravis with acetylcholine receptor antibody positivity, you can also go for thymectomy even if there is no thymoma. Thymoma is not very useful for patients, so not much useful for patients with ocular myasthenia, ocular myasthenia, or anti-musk antibody positive cases, or seronegative cases. Seronegative cases. Seronegative means all the antibody panels are negative. Okay. Now, this thymectomy is never done as emergency procedure. It's never done as emergency procedure. It has to be always elective. So, if the patient is in myasthenia crisis, you should not take those patients for thymectomy. It's never done as emergency procedure. But in the same setting, if the patient has presented with myasthenic crisis, and in the same setting you want to go for thymectomy, you want to do the surgery, you can give some therapy like IVIG or plasma exchange. These are used for acute management of the crisis. So this therapy you can give, and once the patient improves, you can go for the surgery. Okay. Now, so the basic treatment is cholinesterase inhibitor, pyridostigmine, and those who are in those patients where thymectomy is indicated, you have to go for thymectomy. Now, if the patient is not responding to pyridostigmine, that means the patient is the response to pyridostigmine is not optimal. In those patients, you have to go for immunosuppressive therapy. One more point is thymectomy is most effective in this group of patients 18 to 65 years of age. Less than 18 and more than 65, thymectomy is usually avoided. Okay, so next is immunosuppressive therapy, okay, or immunotherapies. Now, immunotherapies, there are various modalities of immunotherapy that is used for immediate, if you want immediate response. An immediate response is needed for the patients who present with myasthenic crisis. Most of the times, myasthenic crisis present as respiratory failure, and usually those patients need mechanical ventilation. For those kind of patients, we use IVIG or plasma exchange. Like in cases of GBS, these are used for immediate response. For intermediate response, what you use is steroid and calcineurin inhibitor. Calcineurin inhibitor includes cyclosporine and tacrolimus. These are for intermediate response. Here the response comes in 1 to 3 months. In IVIG or PLEX, response comes in days. For longer maintenance, you have to use azathioprine or mycophenolate mofetil. Mycophenolate mofetil. Here the response comes in months to years. Even the response may take years to come if you are using azathioprine or mycophenolate mofetil. And the next one is rituximab, and the last one is eculizumab. Rituximab is anti-CD20 monoclonal antibody. It has a specific indication. It is used in patients with anti-musk antibody. This is very important. I told cholinesterase inhibitor, that is pyridostigmine, or even thymectomy, they are not useful for patients who are having musk antibody. But rituximab have been shown some response in these kind of patients. So rituximab has a very specific indication, anti-musk antibody positive myasthenic gravis. Use rituximab. Eculizumab is a newer drug. This drug is already approved for PNH, and this is a C5 inhibitor, complement C5 inhibitor, and this has been studied in patients with myasthenia gravis, and it has shown good response. But the only important concern is cost. Even in patients with PNH in country like us, this is not feasible to use eculizumab upfront. Okay, so eculizumab can be used as a last resort if all other modalities have failed. But again, the most important concern is the cost. Then we'll be studying a little bit about the individual drugs, starting with glucocorticoids. So I told immunotherapies will be started if the response to pyridostigmine is not optimum, or there is refractoriness to the pyridostigmine. Okay. So all these patients we start the first immunotherapy that we start is glucocorticoids. If it is not a crisis, if crisis, definitely you have to go for IVIG PLEX. Otherwise, if it is not a crisis, but there is no response, no optimum response to pyridostigmine, you start with steroid. We'll start with steroid. Usually steroid is given as a single dose to reduce the adverse effect. To reduce the adverse effect associated with glucocorticoids. So usually prednisolone is used. You must be knowing that in many of the immune-mediated cases we start with steroid, and most of the cases we start with a higher dose of steroid, at least 1 mg per kg of prednisolone we start. But this is a condition. This is a very important point. This is a condition. We don't start with a higher dose of steroid. We start with a low dose steroid, around 15 to 20 mg. For an adult, we start with 15 to 20 mg per day. Now, why we start low dose in patients with myasthenic gravis? Because high dose steroid itself can cause muscular weakness, proximal muscle weakness. Okay, so sometimes in acute setting, if you are starting a higher dose of steroid in patients with myasthenic gravis, then you may land up in more and more weakness, because steroid at higher dose can cause proximal muscle weakness. That's why you must have studied in conditions like lupus nephritis, which is an organ-threatening immune-mediated manifestation of SLE, or maybe immune thrombocytopenic purpura, which is a life-threatening condition if the platelet count falls below 10,000. And that is also immune-mediated. In those cases, what we do is we can give a pulse steroid therapy. Pulse steroid therapy is a very high-dose steroid therapy. But in myasthenic gravis, which is again an immune-mediated condition, but here in myasthenic crisis, we never use pulse steroid therapy. That concept is not there in myasthenic gravis, and you need to understand why that is. Why it is not there? Because the reason is this: because high dose steroid itself can cause proximal muscle weakness. Okay, so that's why in myasthenic gravis, steroid is never used as an emergency management if the patient presents in crisis. In crisis, the management is IVIG or Plex. Okay, so we start with low dose steroid. Then we gradually increase the dose. As the patient will tolerate more and more, we gradually increase the dose, and maximum dose up to 1 mg per kg per day can be used. That is around 60 mg per day. 60 mg per day can be used. Okay, so this is known as step-up approach. Step-up approach. And one more important point for this myasthenic gravis, steroid in myasthenic gravis, you have to remember is we have to always do slow tapering. Anytime we start any patient on steroid, we have to taper, because steroids cannot be used lifelong. If you read any immunological condition, there are so many conditions, thousands of conditions in medical science where you use steroid. But in none of the conditions we use steroid lifelong. All those cases we start, and then we have to taper it. And at some point of time, we have to stop steroid, because steroid has so many debilitating adverse effects. Okay, some conditions we do a rapid tapering. Some conditions we do a very slow tapering. This is one such condition, myasthenic gravis, where you have to do a very slow tapering. Otherwise, the disease will relapse. Now, if the patient has responded to steroid and it's a good response, you have tapered the steroid, still the patient is in remission. Patient has shown good response, you can just continue pyridostigmine. But if the patient is still requiring steroid, and you are not able to taper the steroid, then you have to add other agents. Those are known as steroid sparing agents. Okay, the principle is same for any other immunological condition where you use steroid. You have to start with steroid, but ultimately you have to give some steroid sparing agent so that you can reduce the dose of steroid and ultimately stop it. Okay, as I have told, steroid cannot be used indefinitely. Now, what are those drugs? What are those steroid sparing drugs? So those are other immunotherapies. We will start with MMF, mycophenolate mofetil, MMF. I told azathioprine and MMF, they show response in months to years. Okay, they will take time to show the response. They show response in months to years. Even 1 year may take for the response to come. Okay, so the usual dose of mycophenolate mofetil is 1 to 1.5 gram PD. So now the mechanism of action is inhibition of IMP, inosine monophosphate dehydrogenase, inhibition of this enzyme. Now, what this enzyme will do? This enzyme will cause a blockade of purine synthesis. They have a major effect on lymphocytes. Why? Because lymphocytes, they do not have the salvage pathway. This MMF will block the purine synthesis. That is the de novo pathway of nucleic acid synthesis, that is blocked. And lymphocytes do not have the alternative pathway that is known as salvage pathway. You have studied in nucleotide metabolism, you must be knowing that for nucleic acid synthesis, we have two pathways. One is de novo pathway, one is salvage pathway. MMF blocks the de novo pathway. Lymphocyte doesn't have the salvage pathway. So because lymphocytes, they do not have salvage pathway, they are only dependent on de novo pathway. So that's why the effect of MMF is maximum lymphocytes. So they cause predominant lymphocyte depletion. Because of lymphocytes are most commonly affected. Now, what are the adverse effects? What are the adverse effects with MMF? Severe GI symptoms. Severe GI symptoms are seen in MMF, sometimes resembling Crohn's disease or ulcerative colitis. That is IBD. They may sometimes resemble IBD. Then they can cause leukopenia, that is reduction in WBCs. And also there is a slight risk. There is a slight risk of malignancy and PML, very important. Progressive multifocal leukoencephalopathy. This is not the only drug. There are so many other immunosuppressive drugs like rituximab, like natalizumab. All of them can cause PML, progressive multifocal leukoencephalopathy. The second drug is azathioprine. Now this is also a purine synthesis inhibitor. Now this drug is usually started at 50 mg per day, and gradually you can increase the dose up to 2 to 3 mg per kg per day. That means if the patient is 60 kg weight, so maximum dose you can use is 180 mg per day. Okay, that is the maximum dose, but you have to start with low dose. Why you have to start with low dose again for azathioprine? Because 10 to 15% of patients, they may show idiosyncratic reaction like flu-like illness or bone marrow suppression. Other adverse effects include LFT abnormalities. But at this point, bone marrow suppression is very important. I have seen so many patients, especially the hematological patients who are started on azathioprine, and they land up in significant leukopenia causing infections. So in those patients, we have to stop or taper to adjust the dose of azathioprine. Okay. So you start with 50 mg per day, and you can give maximum up to 2 to 3 mg per kg per day. But 10 to 15% of cases, they may show severe idiosyncratic reaction causing flu-like illness, bone marrow suppression, LFT abnormalities. Now this dosing is adjusted according to the WBC level. So the WBC count that we should target is 3000 to 4000 per microliter. As I told, these are bone marrow suppressants, so they will reduce the WBC level. So you can monitor the WBC level and adjust the azathioprine dose. If it is coming below, the WBC counts are coming below 3000, then you have to withhold the drug or you have to reduce the dose. If it is more than 4000, you can still increase the dose. So first we discussed about the MMF, mycophenol mofetil. Then we discussed about the azathioprine. Then we'll discuss about the CNIs, calcineurin inhibitor. This includes cyclosporine and tacrolimus. Now this cyclosporine is started with 4 to 5 mg per kg per day dose, 4 to 5 mg per kg per day dose in two divided doses. And these two drugs has to be monitored. The serum level has to be monitored. So trough level has to be monitored after 12 hours. After 12 hours of the last dose. And what is the target serum level? So serum target level is for cyclosporine, it is 150 to 200 nanogram per liter. For tacrolimus, for TAC, it is 5 to 15 nanogram per liter. Cyclosporine and tacrolimus are more commonly used in transplant settings. Okay, for example, in case of renal transplant, for example, in cases of bone marrow transplant. In those cases, we use this cyclosporine tacrolimus, very commonly used in our practice for in patients bone marrow transplant. And the problem with these drugs is that they have a very narrow therapeutic range. That's why therapeutic drug monitoring has to be done for all patients on cyclosporine and tacrolimus. And you have to remember these numbers. The level is the target drug level is 150 to 200 nanogram per liter for cyclosporine, and for tacrolimus it is 5 to 15 nanogram per liter. The adverse effects you must be knowing, they can cause hypertension, nephrotoxicity, ototoxicity. Auditory defects, nephrotoxicity, hypertension. Apart from that, tacrolimus also has various metabolic side effects. Okay, tacrolimus has metabolic side effects like diabetes mellitus, hypertriglyceridemia, hyperlipidemia, diabetes mellitus, and all those. Similarly, cyclosporine has some effect like hyperplasia gums and hirsutism. Okay, so both of them can cause nephrotoxicity, hypertension, and ototoxicity. Tacrolimus specifically has metabolic side effects like diabetes mellitus and hyperlipidemia. Cyclosporine has separate side effect like hirsutism and hyperplasia gums. Okay. Now next is rituximab. I have already told about rituximab that this is a anti-CD20 monoclonal antibody, usually used in the lymphomas, the B cell lymphomas, and I told this is used for MOS antibody positive cases, MOS antibody positive cases. Okay. Eculizumab, I have already told this is being studied, and in refractory cases it can be used, but the usual indication for eculizumab is PNH. It can be used in myasthenic gravis, but the only important concern is the cost, not readily available in India. Next, one more therapy is high dose cyclophosphamide. This is used only in refractory cases. Only refractory cases. Refractory cases it is used. Only refractory cases. Okay. So these are all the immunosuppressive therapies. I told about the azathioprine MMF. Okay, and these are like to show the response, they will take the maximum time. Okay, months, 2 years. Then I told about the calcineurin inhibitors, cyclosporine and tacrolimus. They show response in 1 to 3 months. Then rituximab, then eculizumab. Okay, and Plex and IVIG, I told these are used for emergency situations in the patient present with myasthenic crisis. The Plex we generally used 5 exchanges, 5 cycles, and each cycle is 3 to 4 liter exchange. Each cycle we do 3 to 4 liter exchange. So 3 to 4 liter per exchange, and up to 5 cycles you can use. IVIG, the dose is similar to GBS, 2 gram per kg over 5 days. So each day you can use 0.4 gram per kg. 0.4 gram per kg. And with this, we can see response in 70% of patients. 70% patients show response with this. Okay. And what are the adverse effects, side effects of IVIG? Basically, fluid overload, because we are giving so much fluid. So fluid overload, acute kidney injury, and one of the important side effects that you have to remember is aseptic meningitis. Aseptic meningitis. So these are all the drugs or modalities that we can use in patients with myasthenic gravis. Then myasthenic crisis, I told these patients usually present with respiratory distress, respiratory failure, and most of these patients will require intubation and mechanical ventilation. And we have to use in acute setting always you have to use IVIG bar Plex. Then you can start with other therapies. Okay, so never use pulse steroid in patients with myasthenic crisis. And the most common cause for myasthenic crisis is intercurrent infection. So infections are most common cause for myasthenic crisis. That is again one more pointer that you should not use a steroid in acute settings. Then sometimes the patient who are already on pyridostigmine, who are already on cholinergic drug pyridostigmine, they may present with crisis, and sometimes it may be difficult whether it is a cholinergic crisis, or it's a myasthenic crisis. For this, you have to know what are the effects of what are the features of cholinergic crisis. So cholinergic crisis is mostly all the effect of cholinergic excess. So nausea, vomiting, diarrhea, sweating. So all those things, bronchospasm, all those things. So if you have features of cholinergic excess, then it is cholinergic crisis. If you do not have features of cholinergic excess, but only muscle weakness, then it is more of myasthenic crisis. Okay. Now, the last point is what are the drugs that has to be avoided? What are the drugs that has to be avoided in patients with myasthenic crisis? So we'll first start off with the antibiotics. So which antibiotics are avoided in patients with myasthenic gravis? So the first group of drugs that is avoided is antibiotics. And antibiotics, we avoid fluoroquinolones, macrolides, and aminoglycosides. Then second group of drugs is quinine group of drugs. From fluoroquinolone, I have remembered quinine group of drugs. Then magnesium, D-penicillamine, Then certain drugs that are used by anesthetists, that is NDMR, so non-depolarizing muscle relaxant, especially the atracurium or vecuronium, rocuronium, all those drugs. And some local anesthetics like procaine should be avoided. Then beta blockers and botulinum toxin. So these are the drugs that are avoided. Now one more drug that is used for our hematological conditions, checkpoint inhibitors like nivolumab. Then those things will be reading later. The nivolumab or pembrolizumab, these are checkpoint inhibitors. They have a whole lot of immunological side effects, and those are also avoided in patients with myasthenic gravis. So antibiotics, fluoroquinolone, macrolide, aminoglycoside. From fluoroquinolone, you can remember quinine is also avoided. Then certain drugs used by anesthesia, that is non-depolarizing muscle relaxant like atracurium, rocuronium, vecuronium. Local anesthetics like procaine. Then beta blocker, botulinum toxin, magnesium, D-penicillamine, and checkpoint inhibitors. So that's all about all the modalities and what are the things you need to consider during management of myasthenic gravis. And this is the flowchart that is given in Harrison. So if it is a generalized myasthenic gravis, start with pyridostigmine and evaluate for considering thymectomy. If I have already told what are the points you have to remember before considering thymectomy, if those things are satisfied, you assess the patient whether the patient can be taken up for surgery. Okay, so if you have to assess the pulmonary function, because you already have a huge mass in the mediastinum, so you have to assess the pulmonary function by doing the spirometry. If you have a good forced, if you have good vital capacity, forced vital capacity, and then definitely you can go for surgery. If you do not have a good pulmonary function, then you can treat with drugs like plasmapheresis or IVIG, as I told. For crisis, you have to treat those patients with these drugs. And once they respond, once they improve, you can definitely go for surgery. And after that, you can continue with immunosuppressive therapies that I have already told. Okay. If the patient presents with crisis, then you have to do intensive care like intubation, mechanical ventilation, supportive management for sepsis, because the infection is the most common cause for precipitation of crisis. So those things you have to do, but along with that, you have to give IVIG or PLEX, and then you can think of immunosuppressive therapy or thymectomy. Now, if the patient has only ocular myasthenia, you have to rule out secondary causes of ocular involvement. So MRI has to be done for those patients, and the treatment is again pyridostigmine. If not satisfactory, you can go for immunosuppressive therapy. For ocular myasthenia, again, thymectomy is not very useful. I have already told ocular myasthenia, thymectomy is not useful. Start with pyridostigmine. If not useful, then go for immunosuppressive therapy. So the basics is very clear. All the patients has to be treated with pyridostigmine, acetylcholinesterase inhibitor, except the MuSK positive cases. MuSK positive cases, they don't respond. For them, use rituximab. Otherwise, you have to start with pyridostigmine and assess for thymectomy. If indication is there, go for thymectomy, and then continue pyridostigmine. If response is not proper, start with immunosuppressive therapy. For crisis, you give IVIG PLEX for acute management, then assess response for thymectomy. If you can do thymectomy, do thymectomy. If you cannot do thymectomy, just start with pyridostigmine. If response is not proper, go with immunosuppressive therapy. I hope with this, it is very clear now how to manage myasthenia gravis. So my sincere request is, you always, after listening to this, you have to go to Harrison and read the management part again. So thank you.